Okay, we are live streaming.
Okay. Hello, everybody.
Not yet. Let's wait for a few people to join first.
Have we got people?
No, we've got 0 people watching at the moment. There's a little eyeball on the top. We've got 5 people watching on YouTube.
Okay. That's reassuring. Let's see. So the guy we did the other day, he's going fine, Munjed?
Yeah, he's good. He's fine. I think he's going home. So everything's fine.
Or discharged out of hospital. He's going to stay in Sydney for a while.
Yeah, so I think he's going to the marathon and staying in the hotel for a while. He wanted to stay for the lengthening, some of the lengthening period.
Yeah.
Yep, which is good.
Okay, we'll just wait 1 more minute before we start.
How many people have you got?
15.
Okay.
They already see and hear us?
Is what?
Do they already see and hear us?
Yes.
See. Yep.
Oh, good.
We are streaming live.
Okay, you can start introduction.
All right. Today we have Dr. Kevin Tetsworth and Professor Al Muderis here. Kevin, why don't you say a few words and introduce yourself?
Sure. Kevin Tetsworth. I'm active as an orthopedic surgeon for 35 years. I've been here in Australia for almost 25 years. I practice in Brisbane and in Sydney together with Munjed Al Muderis and at the Limb Reconstruction Center there at Macquarie University Hospital. That's where we do most of the complex things, the osseointegration, the stature lengthening, lots of this sort of complicated business. And in Brisbane, I do lots of high energy trauma and segmental bone defects and that sort of side of things as well.
Thanks, Kevin.
Okay.
Munjed?
I'm Munjed Al Muderis, an orthopedic surgeon. I've been in practice for 15 years. I'm professor at Macquarie University and at Notre Dame University, and I'm an associate at Sydney University's School of Engineering. I work at the Limb Reconstruction Center at Macquarie with Kevin. We have very good collaborative relationship and friendship and partnership in dealing with high-end complex orthopedic problems. We specialize in deformities, deformity correction, infected joint replacements, failed joint replacements for one reason or another, leg length discrepancies. We specialize in stature lengthening, and I have a special interest in osseointegration surgery and particularly in patients who suffer from complex regional pain syndrome and chronic disabilities.
I think both of you are selling you are a little bit short. These two are two of the most famous limb reconstruction surgeons you can have on this planet at the moment. So it's a great honor to have both of you online at the same time.
Thank you.
And we do have a lot of questions from the audience already. Thanks for everyone who have already sent the questions in. It covers a wide range of topics, and today we'll be covering amputation, osseointegration, basic joint replacements, limb lengthening, limb reconstruction, as well as deformity correction. And in many cases, it's a mixture of all these different topics. So without further ado, let's start with some questions on osseointegration. So Munjed, maybe this one's to you. What is osseointegration for those that not aware of it?
Bone-anchored prosthesis or osseointegration surgery for amputees is an innovative technology involved revolutionizing the rehabilitation of amputees. Traditionally, the socket-mounted prosthesis, it's a technology that's been there for 600 years. It hasn't changed. It's encasing the residual limb like a bucket or a socket that wraps around the leg. With osseointegration surgery or bone anchored prosthesis, it's a high tensile strength titanium implant that is inserted into the residual bone, whether it's the femur or the tibia or the arm. And it's connected through a small opening in the skin to a prosthetic limb. At the same time we do osseointegration surgery, we reorganize the muscles, reorganize the nerve in order to optimize the functionality. And it has multiple benefits. The main benefit is improve in mobility. The second benefit is to eliminate the socket-related problems, including the socket-related pain. Third benefit, if it's associated with TMR or RPNI, where we work on the nerve, is to help with the phantom limb pain and phantom sensation and neuropathic pain. This technology is becoming a standard of care in many places, and it is more acceptable now than before, since the numbers have increased, and it showed its validity and efficacy and efficiency in helping people with their mobility.
Okay. Kevin, anything to add to that? What are your thoughts?
That sums it up. I think that again, it's a way, it's a path to rehabilitation. It's an alternative to a socket, and there are those patients that aren't suitable for a socket for a variety of reasons, and certainly there are people that do very well with a socket. Those people that have difficulty with a socket for a number of reasons. They either have a short stump, they have limited soft tissue, they have and scarring, or they may have propensity, or they may be prone to get ulcerations or folliculitis related to use of a socket. So, and there are these people that just can't be fit with a socket for whatever reason. They've had 5, 6, 7, 8 or more attempts to fit a socket. Those people are great candidates for osseointegration as an alternative way to attach a prosthetic limb to their skeleton and allow them to regain their mobility.
Mm-hmm. So, as a surgeon, maybe this question is more for Munjed, both of you actually. When do you decide to amputate? What's the consideration process?
In my books and from the literature and from our experience, we amputate for several reasons. Number one, if the limb is dangerous, and that is in case if the leg is severely infected, gangrenous, and it's not viable, and it's causing the risk of transmission of infection into the rest of the body and kill the patient. That's one time where we amputate. The other time, if the limb is dead and it's not functional, if a patient loses completely the sensation and the power in the limb, then it becomes dead. And especially if there is dry gangrene, the limb is dead. The third reason, if the patient have a nuisance of the limb, and these kind of conditions, for example, if the patient has a fused joints like fused knee, fused hip, fused ankle, and fused foot, and it's like a log, and it's not sensate, so the patient cannot mobilize, cannot get in a car, cannot mobilize into restaurants or sit in a proper chair, then that is an indication for amputation in certain circumstances, where a prosthetic limb will be better off for the patient than the limb that they have. There are other circumstances that are emerging now, such as patients with intractable complex regional pain syndrome that is not treatable by any of the non-operative means or any of the pain management means. If the patient reached a level where the complex regional pain syndrome is affecting their life and inhibiting them from their mobility and affecting their sleep, then there is an indication of amputation with nerve reorganization from that point of view. And I'll see if Kevin has anything to add on
Sure.
to that.
Yeah, that's a great introduction. I think that a way of approaching the problem for the what we call cold trauma setting, or the cold setting, where people have had an injury in the past and then are considering the alternative of trying to reconstruct or have an amputation as a way to move forward with their life. I deal with a lot of the high energy trauma, the acute trauma at the Royal Brisbane Hospital. It's one of the larger trauma hospitals in Australia, certainly. And the issues there in and around people with complex high energy trauma involving their distal tibia, open fractures of the tibia, the distal tibia, foot and ankle. Anytime you need flaps and things, you enter this other category. So the high energy open fractures with bone loss. And it's quite interesting. When I was in Baltimore, so I was George Paley's fellow for a year in Baltimore, and then I was in Atlanta with George Cerny for a year doing osteomyelitis and musculoskeletal infection. I practiced there for 10 years. And as part of the time I spent in Baltimore, working together with the team at Shock Trauma, as well as at the University of Maryland system. And part of a big study that was organized out of it was the LEAP project, the Lower Extremity Amputation Project. And that was a randomized controlled, no, it wasn't even a randomized controlled trial. It was a big study where they looked to see, observational study really, almost 600 patients in 18 trauma centers across the US to see how people did. Did they do better if they had an amputation or limb salvage? And in the end, the conclusion was that actually people do equally bad, I will say. You know, the paper says they do equally good, but no, they do equally bad. About 50% of them ever return to work. This is people with complex high energy injuries below the knee, open fractures. And the ones that did are particularly bad were the ones involving the foot and ankle. So if you need a free flap in and around your foot and ankle, you're unlikely to get a good outcome. And so now we know, we did this big study, 600 patients. I had about 3 patients total in there, but that's a fair bit of involvement and contribution to it. And we know from this study that a lot of it is determined by what your social situation is like, what your education level is like, what your employment is like, what kind of support network you have around you. That a lot of that determines how you actually respond to the injury ultimately. So we can say with some confidence that, for me at least, when I have a patient with a bad injury, I can let them make that choice, that whether they want to salvage or not. I have a big frank discussion with them, but ultimately it's up to them, and I can know that they have an equal chance of having the outcome that they want. Now, it's an equal chance that it won't be the outcome that comes, but that's predetermined before they had the injury. Is a weird way of looking at it, but that's the facts. And we also know that the best outcomes for people who have terrible trauma on the foot and ankle in particular, and need a free flap, they actually do better with an amputation than trying to salvage it. So I have this discussion quite frequently. People, it is not to be thought of as a failure of treatment or a failure of the surgeons or modern medicine to be able to save their leg. We make a decision based on the expectation that they will be better. It's a better form of reconstruction. Amputation is actually a beautiful reconstructive procedure, and they can do better with that than trying to save that limb in certain circumstances. Sure, the vast majority of people, they have open fractures, we put nails in, we put free flaps on, we salvage their leg. The ones in the middle of the tibia, in the shaft of the bone, that we can salvage, that we can reconstruct, that we can grow new bone. We have a difficult time regrowing all the small joints and making a foot functional again, especially if it needs a free flap, because then it's hard to fit into a shoe. And that becomes the biggest determinant in terms of how their outcome is ultimately.
Mm-hmm. Thank you. Mm-hmm. So when one considers osseointegration, how long does the residual limb have to be?
Length is important. However, within our unit, we have significant experience in lengthening residual bone. So the minimal amount of bone that you require in the femur is around 10-12 centimeters. That can have a standard osseointegration implant. The shortest tibia we have performed is 5 centimeters as a standalone implant. But anything shorter than that, you would require to lengthen the bone, which is a successful procedure that we have developed an implant that is inserted into the femur or into the tibia, and you can gradually distract and lengthen the bone over a period of time, and then after lengthening, you go through a period of consolidation, and then you can choose whether you go back to a socket prosthesis or you choose to have osseointegration surgery. But the shortest femur we've dealt with was a young lady from Belgium, which was like around a centimeter of the femur. We managed to lengthen her 10 centimeters, and she had a successful osseointegration surgery. And the shortest tibia I've dealt with was around, again, 2 centimeters of the tibia, which we managed to insert an osseointegration with a total knee replacement in 2012, and the patient still functioning as an engineer and fully operational.
Right. At that point, it becomes it's sort of difficult, especially with the proximal femur. How do you actually measure how much residual bone there is? Because there's the head and neck, and then, do you count that or not, or do you count from the tibia greater trochanter, or from, what anatomical location? And so it's a bit of a vague definition of how actually long, for instance, the girl from Belgium, how long her actual femur was. It was very, very short. We did a very interesting design for to lengthen that bone, and worked out spectacularly well, I think. But yeah, how long is it? I don't know how long it really was to start with, but now it's 10 centimeters longer, and it fit a standard implant, which is good.
So it sounds like length is not a contraindication. You have ways to work around it.
Yeah, length is not a contraindication. However, you need to if you have a short residuum, you need to go to a center where they know how to do lengthening, and that's very important.
The important part of the length is not necessarily that the implant fits, but in fact, the longer that residual bone is, the longer the femur is, for instance, the more of a lever arm you have for your muscles to act on. And for instance, the guy from Ireland, I think it was the Irish guy, who I think he was maybe 7 or 8 centimeters. You could have done an implant in him, but by lengthening his femur first, it brings the muscles down together with it, and then that is much more effective, has longer lever arms, and is a much more powerful way for him to mobilize for the remainder of his life. A young guy, I think he was in his early 30s. Well, he's got 50 years of life left. He should spend that extra time, the extra 7-8 months it takes to get the length, to wait for the bone to heal up, to delay the definitive osseointegration procedure to get the length, because for him, so important to get that additional strength and will improve his ultimate mobility and his function.
Yeah, and especially that he wanted to become a commercial airline pilot. Back, he was flying for Emirates, and he wanted to go back to flying 777s. So you need to have strong lever arm in order to manage the rudders.
So say we've solved the problem of length. How does the implant actually work? How does the term osseointegration actually work so that it fuses with the bone?
The bone basically heal on the implant. So as long as there is a medullary cavity that an implant can be inserted in it, the bone heals on it, and then the muscles can operate that limb. So everything stretch, and once it heals, you can lengthen legs basically, and you can lengthen the sarcomeres. They don't multiply, but they just stretch. And Kevin can comment on that, I think.
Well, the Swedish dental surgeon Per Ingmar Brännmark, who's really not necessarily the pioneer of osseointegration surgery for amputees. His son is Recon, but he's the one who discovered in rabbits, I believe, working, that titanium is very biocompatible, and bone grows into, if you leave some little interstices, a porous surface, make it sort of a spongy bit of a surface to the titanium implant, bone grows into it. And that was really the key to having implants that didn't need to be cemented to the bone, and instead the bone grows directly to it and becomes one with it. It becomes continuous with the implant, which is amazing. And but fortunately, we can use that to our advantage. Put the implant into that part of the skeleton inside the bone, let it grow onto it over the course of 6, 8, 10 weeks, somewhere in there. Grows in very reliably. We don't need to do anything to augment that, to improve how that takes. So that's just the basic science on that side of the bone growing to the implant. In terms of the muscles, all your muscles are made of long chains of things like sarcomeres. Munjed just mentioned that they're sarcomeres. They're like little tiny chains, links in a chain. And if you have a limb lengthening under the age of 20, you grow more sarcomeres. If you are over 20, and it's not like, oh, on your 20th birthday, no, but let's say that you're 25, 30, certainly, by the age, once you're well over 20, your sarcomeres, you don't add any more sarcomeres. So under 20, you start off with, let's say, 5,000 sarcomeres, and it becomes 6,000, 7,000. You make the muscle longer as well. It grows new functional units. When you are my age, or really anybody over the age of 25 or 30, instead, each sarcomere stretches out a little bit and it deforms. And so that causes scarring and fibrosis. And that muscle is not going to be normal or the same. It does function well. We do the lengthenings. Ilazarov demonstrated this 50 years ago, that you could lengthen limbs and lengthen not only the bones, but the muscles, the nerves, the tendons, the blood vessels, the skin, everything. There's a embryogenesis. There's more new tissue that forms, not just stretching it, but more new tissue. But in the case of the muscle, after you reach a certain age, no, it does not grow more muscle. It simply stretches, deforms. It still functions reasonably well, but it is not normal, and you lose some of that elasticity to it and some of the strength in it, inevitably.
Mm-hmm. So we have a live question here on this topic. What options are available for extending this bone health? Are there any medications that you can recommend, or is there a lifestyle thing that you can recommend to your patients to maintain this bone health for the long term?
Bone health, you're saying?
Yes.
Yeah, bone health is an interesting thing. By the time you get to be, again, 30 years old or so, again, so it's a rough sort of a thing, and certainly in women, you form most of your bone mass that will be there for the rest of your life by the time you're about 30. So if you are really active and run a lot and make the bone do work, it grows bigger and stronger. It's called the Hoyer-Volkmann law. And the same as your muscles, like me. If you work out a lot, your muscles get big and strong. If you make your bones do a lot, the bones get bigger and stronger and denser and harder. And so someone who is relatively athletic and spent their whole life, I played basketball and baseball and football and track and done things. Yeah, my bones are dense and hard. If I was more sedentary, if I spent my youth playing lots of video games and smoking and drinking, no, my bones would not be as dense as hard. Now, you get to be 30, 35, 40, then you start to lose bone mass. And for women, it accelerates very rapidly, especially after menopause. Their bone density and things sinks rapidly. For men, it continues because we don't undergo menopause. And so we don't have this rapid drop off after that point of 45 or 50. Instead, we just continue to gradually reduce bone mass and bone health. Now, if you do remain active, physically active, there are people in their 70s and 80s that still participate in athletics and play tennis and golf and are physically active, and some of them run marathons and things. Sure, their bone health is better. It's not the same as it was when they were 30, but they have lost less of that bone mass because they have remained active. And so by making your bones do work, they stay big and strong.
And this is one of the most important advantages of bone anchored prosthesis or osseointegration surgery, because patients who use the socket, they don't load that bone. So it can be that the rest of their body is healthy, but the area that is encased by the socket, that bone is not loaded, and with time that bone will become more osteoporotic. When you take an X-ray of both legs, the amputated limb and the intact limb, when you see it first, and we've done 4 publications so far about DEXA scan and the bone mineral density on amputees with a socket, compare them to the osseointegration, and you can see massive difference. And then with time, after they get the osseointegration with the bone anchor prosthesis, their bones strengthen and they build bone back again into a healthier status, because you load bone, you form bone, and that is Wolff's law.
Yeah, we wrote those papers with Seamus Thompson. He left to go work at NASA. An interesting guy, a very smart guy. But yeah, we demonstrated that very convincingly. The papers are good that demonstrate that loading the bone with an osseointegration prosthesis, the bone, because many of these people, if you've had an amputation when you're 6 or 8 years old, your bone never had that chance to build up and be big and strong again. It's a different thing. If you grew to be 35 and then you have a tumor and you need to have an amputation, yeah, you have a normal femur. If you had something happen to you when you were 4 or 6 years old and you've never really walked on that and it never had the demands placed on it and that bone never hypertrophied, never got big and strong, it's very weak to begin with. But when you load it with the osseointegration implant, yeah, it can become bigger and stronger. We've seen it many times.
So guys, exercise. I think that's all we need to know. As long as you use it, you'll be able to maintain it.
Use it or lose it.
So the next question, are osseointegration implants hard to maintain? What in terms of maintenance are patients required to do?
No, they're not. The maintenance of osseointegration is similar to maintaining a socket. As a matter of fact, it's less maintenance. The breaking parts are much less because with a socket, you need to change the line every 6 months to 1 year. You need to change the socket every few years. And some people, we have patients who change sockets maybe once or twice in their lifetime, and we have patients that change 18 sockets in 2 years. With osseointegration, it's unless it gets infected, unless it's fractured, you don't need to change the implant. But the external components, the dual cone, need to be changed every 2 years. The connectors and the prosthetic limbs, they need to be serviced and changed on a regular basis with the prosthetist, similar to what you use with the components, the external components of the socket prosthesis. So you're replacing an implant with to what you have with a socket prosthesis. So maintenance wise, if there is no complication, it's much less, basically.
So on the same topic, maybe this one to Kevin. What are the most frequent complications of osseointegration that you have in your experience?
Right. So when we look at complications, the thing that everybody worries about and everybody frets over, and the thing that we advise patients, they will have essentially a 100% chance of having some element of infection at some point during their clinical course. 100% chance. That doesn't mean that it's 100% chance. Not every single patient does, but many patients have, especially early on in the first few weeks. There's some colonization of that opening. So we used to call it a stoma, but the stoma is more what you use with a colon and that sort of gastrointestinal kind of connection where it exits out for people that have had colon cancer and things. So instead, we've gone to calling it an aperture or an opening. It just means where the implant exits through the skin. That opening, like every other opening that you have in your body, your eyes, ears, nose, mouth, any other openings you might have, they become colonized with bacteria that are normal to that area. And your body adapts to it and is in this symbiotic sort of relationship with the bacteria. More of your mass of you is bacteria than it is you. In fact, if you measure up all the bacteria in your body, more of you is bacteria than it is your human cells. Now, you have this risk, and most of the time, you're able to keep the bacteria at bay. You have a relationship with them where they exist and you exist. You coexist with them. when you get sick for whatever reason, when you have something else going on in your life, various things, you change your diet, you change your location, you get a new pet, you get exposed to new different bacteria, then you have this risk that that opening, the aperture, will become colonized with new bacteria that your body is not used to. There's an adaptation process for a period of time, and you don't have any way to predict that because you don't know where those bacteria are. You don't know where they're coming from. It may be that you went swimming in a lake. It may be you got a new girlfriend and you went and her shower has different, bacteria. Whatever it happens to be, you're in a different environment. All these things can influence the bacterial colonization of the aperture, and that puts it at risk of getting what we call a localized infection. Now, colonization, not an issue. Localized infection, then you need to be put on some kind of, usually we try some oral antibiotics, see how you respond. If you do well, that's good. Most people do well with that. And there's about an 18% overall chance of infection that needs some sort of antibiotics. About 2/3 of those people, so 12%, respond to just oral antibiotics. And the other 6% either need IV antibiotics, and of those, about 2% of that, in the big series that we've looked at it, needs to have some sort of surgical procedure to clean out the wound, wash up, and other things. So that's the risk of basically infection. Other potential complications. Well, yeah, you can have pain because it's not really a pain relieving operation, and so the association. Many amputees already have pain. They have chronic pain. That's why they had the amputation. So trying to manage the pain, we do these things like TMR, RPNI. We have pain specialists that we work with that are very intimately associated with us, that work together with us closely to try to manage it immediately post-op, perioperatively, meaning intra-op and post-operatively, and then ongoing over time. And for most people, we can do that successfully. Some people, no, they continue to have pain, and that's a different, there's so many things that go into pain. That's a different, whole other topic to go into. So but again, not a pain relieving operation, but we do things in addition to the osteo to manage the pain. So we consider pain, intractable pain would be a risk, and you would consider it a possible complication. Other things, there's general medical kind of complications where you can have blood clots form in your leg and in your opposite leg often, that will go to your lungs and things. So, forming DVTs or having a blood clot, a PE, I think less common, but you may need blood transfusion, early post-operative, things like that. Sometimes another issue is the soft tissues over time, especially we found that it was women whose collagen is more elastic. My collagen is very tight. And most women, especially middle-aged women, collagen is looser. And so over time, much like other tissues on their body, they tend to hang down with gravity. And the same thing, particularly with the transfemorals, the above knee amputee, that soft tissue has a tendency to migrate down and starts to impinge on the implant and things. And that can be an issue. So sometimes people need to have a stump refashioning, which I think is a really effective procedure. The risk there was greater in women, greater in people over the age of 50, I believe, greater in higher BMI, as you might expect. So what we want is some kind of soft tissue envelope that surrounds the implant that's really very stable and doesn't wiggle or move. That would be ideal. And so if you have one that's a bit looser, flabbier, wants to hang down, etc., it can create other issues or problems. Munjed, you can chime in. I think there's other things to talk about, fractures and all other possible complications. Sure.
Yeah. So in sum, I think you summarized it very well. Infection is the greatest risk, and majority of it is superficial, as you correctly stated. Small minority that requires revision or surgical intervention. Granulation tissue, which is activity related. Leakage and discharge from the stoma. Prosthetic fracture, which is similar, it's 5 to 7%, similar to the socket prosthesis. Breakage of the implant, touch wood. We haven't had a breakage of the titanium implant that we designed, but we had multiple breakages from the 3D printed implants that are done. So we don't do 3D printed implants anymore because they lay the layers on top of each other. So the axis of the breakage is perpendicular to the longitude of the implant, and that cause them to fatigue, and they get crack propagation. So that's why our implant is forged and solid, and breakage of the safety mechanism, which is designed to break. And other than that, you get pain, chronic pain, which is related to the stimulation of the nerves. Like some people get neuropathic pain, but that's rare. Usually people who start with pain, they end up with pain. People who don't have pain, very rarely to end up with pain.
You know, I think it's also important. So we've gone over time. The original Swedish philosophy was to do 2 stages, to prepare the bone, put the implant in, cover it all up, wait somewhere 12 to 18 months, allow the implant to grow to the bone. It's a different type of implant. It's the OPRA system is a different kind of implant. It's not a press fit like the OPL is, the one that we use. So it was really a different philosophy, and it was put in, then allowed to heal in over a long period of time, and then create a secondary procedure where you then create the aperture and then attach the limb. And Munjed's experience early on was, he adopted that same principle, but found that it was better, in his opinion and experience, to go to a single stage, to do it all at once. And the data actually supports Munjed very convincingly in terms of the number of reoperations in terms of stump refashionings. I think that when we looked at a long series of them, we compared the 2-stage operations to the 1-stage. For transfemorals, the stump refashioning rate was 10 times less in the single stage. I mean, really impressive. And again, that also reflects obviously Munjed's experience, his first 75 cases or so, where the first 75 cases he's done of any osseointegration, those were all 2-stage. And now we preferentially do 1-stage. Occasionally there still is a role for 2-stage when there's active infection, when the bone quality is, certain factors that sometimes play into it. We prefer to do single stage. When we do need to do 2-stage, you've already identified that patient as being at risk for various reasons. So it's not really a fair comparison in that sense. But the facts are, no, single stage, it's 10 times less risk of needing a stump refashioning.
Yeah, and we're writing a paper about when to do single stage, when to do 2 stages, and the only indication for 2-stage surgery is if there is active infection, as Kevin said, and if we are lengthening the bone, or if there is a significant deformity in the bone that need to be corrected before opening it to the outside environment. These are the only times that I can think of that you do 2-stage surgery. Otherwise, at all other time, single-stage surgery is the way to go.
Yeah, the one guy that we had, I'm thinking, you'll remember one of the transtibials that I brought down from Brisbane, who had terrible soft tissues. He wasn't actively infected, but the soft tissue, he had ulcerations and things overlying the tibia. And Munjed did a very impressive job of refashioning the soft tissues and moving it around to cover those openings in his skin before we went to the definitive implant. So, that was really quite impressive to see.
So thanks for all this information on osteo. We would like to cover some more questions in the limb recon space. We will come back to osteo later. So both of you work also extensively with patients with limb deformity. So let's start with something as a background. What are the most common types of deformities that you encounter, and how do you determine the best course of treatment for a patient with limb deformity? I might get Kevin to start on this answer.
Sure. We classify generally in the big picture there. They can be congenital or developmental type of deformities. where they're either born with something or as they grow, their growth was disturbed. And these are often young patients, often with terrible deformities, some of them that are difficult even to describe or categorize. And that's one separate category. The other main category is post-traumatic. Someone that grew up completely normal, has a leg that was the same as the other one. Essentially, it's a mirror image. You have two hands, they're mirror images of one another. 2 feet and 2 legs, they're mirror images of one another. So in that instance, you have some trauma, something happened to you, you broke your leg, it got fixed for whatever reason, it healed with some kind of deformity, and sometimes it's bent in, sometimes it's bent out, sometimes it's rotated, sometimes it's bent forward. And most often, Stuart Green looked at this, 96% of the time, the trauma ones are a little bit of this and a little bit of that. They're not just one element. They're not just bent in and in valgus. There's some valgus, some rotation, and some anterior bow, some procurvation to it, we would call. So 96% of the time for tibias, that was true. 4% of the time, it was in a single plane. Now, the easy thing there is we know what it's supposed to look like. It looks just like the other side. And so now, in fact, we do a lot of modeling with, certainly in the computer, in the virtual world. We have a young colleague who's a whiz at it and is, a brilliant and a great guy to work with. We love Mustafa Al-Tahir, Dr. Al-Tahir, whose primary training and specialty was foot and ankle, but he's adapted or adopted this as another big interest of his, is in doing all the modeling. So we have him do all the modeling, do the mirror images, do the virtual surgery, create jigs and guides to show us how best to do the osteotomies and to correct things acutely, very accurately, very reproducibly. It's a marvelous way to do it. Back in the day, sure, I trained with Dror Paley. We wrote papers together that describe methods or techniques to do the deformity planning, following certain rules and principles. And, those have been adopted worldwide with some enthusiasm and rightfully so. Dror, did a fabulous job of putting that together, adapting or learning from Ilazar of the principles, and then promoting it and putting it, codifying it, as he would say, putting it into a formal arrangement where you could teach it to people. And that's the important thing, being able to teach many surgeons. We can only, Munjed and I, or any individual surgeon, even if you did 600, 800, 1,000 cases in a year, you teach other surgeons, and then you teach 100 surgeons, well, now you can reach 100,000 patients in a year. So it makes it more generally available. And that's, in a sense, in a broad sort of sense, there's either congenital and developmental deformities, or there's post-traumatic deformities. Munjed?
Yeah. So the way I look at it is exactly how Kevin described it. It's I look at it as causation, deformity based on causation. So, and that is congenital or acquired. The congenital can be like dysplasias, people who have either dysplastic hips or deficiencies like hemimelias that cause deformities. And then the acquired can be childhood induced or adulthood induced. The childhood induced, usually I have a special interest in polio patients where they develop significant amount of deformity, and I deal with adult polio very often, where they have massive deformities. And then you have people that develop, for example, multiple exostosis, hereditary exostoid diaphyseal eclasis, where they get deformities because they get tumors in their legs and that affect the growth plate. And then you have the acquired that goes in adulthoods, which is infective process. If they have osteomyelitis, for example, and they get resections, or they have traumatic, where they have car accidents, and they end up with deformity of their limbs. And then you look at it outside the causation. Obviously, there are certain diseases that cause deformity, like tumors and conditions such as certain conditions that can cause deformity as well. But then you look at the the actual like implicator of the deformity, which is either it's a coronal plane, sagittal plane, rotational plane, as Kevin said, it's always a combination, or leg length discrepancy. And whether it's only bony, or it's bony and soft tissue, or whether it's driven by the bone or driven by the soft tissue. So the deformity is a whole world. It should be a specialty in its own. Because it's really complex, it's really, but it's very fascinating, very interesting, and the effect of treating deformities has an immense outcome on the patient life, as long as you know what to do. And as Kevin said correctly, we have the technology that is not available anywhere else that I know of. It's very rare. I mean, Kevin has a similar system in Brisbane. But nowhere else around the world that I've worked that have seen like a person like Mustafa Al-Tahir doing the 3D modeling and creating it, because usually it's an engineer job, but because he's a surgeon, so he knows how to 3D model and think in an orthopedic surgeon perspective rather than engineer perspective, and that adds another level of accuracy and simplifying the way to look at it and to address it. So deformity is basically what we are fascinated about, and it's our core practice basically, and it can be corrected.
And the interesting thing about the way that's done in Sydney at the Limb Reconstruction Center there at Macquarie University, the model of care there is that patients go, you have your sophisticated study, you have your EO scan, you have your CT, weight-bearing CT, or regular CT, and then it is modeled in real time right in front of you. You come back into the clinic, it's a multidisciplinary sort of a clinic, and we have prosthetists and rehab physicians and all the surgeons, a number of surgeons that sit there. Mustafa does the modeling right in front of you. You can observe how it's done. That is the really unique thing of that clinic. Many places provide a certain, you get a CT scan, they send it, somebody models it. 6 weeks later, you come back and they've generated some. No, this is done in that 15 minutes after you come back from having your studies done. And you get an opportunity to peek behind the curtain, as it is, or as it were, to be able to see how that process unfolds and to hear the discussion. We have a bit of friendly banter between us, the opinions of the surgeons of how best to correct the deformity and what elements need to be considered first and addressed most urgently, and have a bit of a debate about it. So I think for the patients, they get a big kick out of it, I'm sure, to see all that unfold. Otherwise, it's this black box where they have a study and then say, come back in 6-8 weeks, and then somebody will model it somewhere, and the surgeon may have a little bit of input, but the engineers dominate that sort of thing, or they ask you for your input, and then they kind of have their own concepts of what you want to do. But as Munjed said, Mustafa, by being a surgeon, he understands how we need to position the jigs and guides in surgery, what the limitations are, what the problems are, where we would typically put the jigs and guides. And having done well over 300 cases now, because he has been there for 3.5 years. It's about 100, almost 100 cases a year, I'm sure, that he is modeling, and we are using those jigs and guides and using them quite effectively. So it's become a routine part of our practice. And I think it's really the model of how these things will be done in many circumstances around the world. Most places would love to be able to do this, but they don't have that capacity because you don't have all those things in place. But it's a great setup there in Sydney. That's why I'm so fortunate to be able to continue to be involved there, and happy to go there and participate. It is a really unique sort of experience, but I can't duplicate in Brisbane. Why? Because my engineers, as much as I work very closely with them, no, I have to send them they'll do it. It'll take them 48, 72 hours. I work closely with them. They're with me in clinic seeing patients at the same time. It's a bit of a different model and very difficult to duplicate or replicate anywhere except for in Sydney at Macquarie University. The other thing is, but besides deformity, there's also, my special interest is in bone defects. And so having a segmental defect, again, a whole other topic of how you generate or regrow bone to fill defects of various sizes.
Yeah.
So this bone modeling in clinic, just so for those that can't really picture it, it's all done in 3D, right?
Yes.
Maybe Munjed, you can talk about this. Like, how does it impact you as a surgeon looking through CT slices versus having a 3D model?
The biggest importance of the 3D modeling is that it comes in 3 dimension, because we do X-ray, CT scans, MRI scans, all single dimension. You look at it from one, and then you try to imagine what happens in the other dimensions. While with the 3D modeling, it's all moving in front of you. And the biggest advantage that you have is that you can perform the surgery on the computer. The patient is sitting there in the room, in the clinic with you, and you're looking there. And as Kevin said, we have a bunch of surgeons that sit around, and there is the anchor, which is the traditionalist. There is the conservative, and there is the dreamer, and there is the thinker. And we have a very good combination of surgeons there, and you can.
Are there 2 thinkers?
You have 2 thinkers, and you sit in front of
Munjed and I,
them.
2 thinkers.
Yep.
Dreamer is Mustafa.
Your Mustafa is the
Conservative
dreamer.
is Tim, and
The conservative is Raz. Yeah.
funny.
So that's the team, and it's a very good harmonious combination between us, because it's a balance where you get different people intervening from their perspective, and the procedure is being carried on how we want to do it on the model, while the patient is sitting there in the clinic watching the procedure is performed on their virtual leg, and then looking at how the leg is corrected and how the deformity is fixed. And it's fascinating. A lot of the patient, they come out of it very satisfied, looking at what this will happen in the surgery. It does have a great positive effect on the consent of the patient, because the patient understands very well. It does have a very positive effect on the surgeons that we can achieve that kind of correction, and it does, in fact, in reality, makes us as surgeons look very good when we are performing the surgery, because we can accurately apply what Mustafa does on the computer on the patient in the operating theater, and it cuts the surgical time dramatically by more than 50% easy, because you have a very well designed and orchestrated plan, and then you just implement it in theater with confidence, because we get all the results printed out into our computers, and in the operating theater we watch it as Mustafa has done it on the computer, and we can apply it on the patient. So there is a huge advantage to this technology.
And I will just say this: I live in a 3D world.
Yeah.
When I want to see something in 2D, I go to the movies. So I need to have it in 3D. I am very good at imagining things in 3D and doing 3-dimensional surgery. I think not all surgeons are as adept at that. Munjed is very good at it. I know that there are lots of people that shy away from certain types of surgeries because their 3D perception isn't as good. They may end up being hand surgeons and things like that, where they do intricate, tiny little things that they don't need to think about things in 3 dimensions. It sits right in front of them, and they can, do tiny. I can't do those tiny things. My hands are too giant to pick up those instruments sometimes, and so so I've gravitated to parts of surgery that suit my skill set. And for me, thinking in 3D and working in 3D, that's my natural habitat. And again, like I say, I live in a 3D world. I go to the movies to see things in 2D, and so I need it modeled in 3D.
Yeah, and it makes a lot of sense, basically.
Sounds like we're gonna do a lot more of this in the future too. So I have a question from a mother. She has a child aged 12 years old. If her child and the mom would come to Sydney for treatment for complex limb reconstruction surgery, how would that whole journey and aftercare look like?
Well, it depends on the nature of the surgery. If it's a deformity correction, where are they from? Where are they
From
based?
the US.
From the United States, yeah. And usually the patients have consults with us from on Zoom, and a lot of the planning is done by sending the material and the scans, and by just sending the decom files, our engineers can 3D model it and plan the surgery, and then we can have telehealth consults. I think one of the things that we benefit from COVID was the whole creation of telehealth and Zoom technology with consults. Now it is well established that we can have conferences over the internet, and it's well acceptable as a practice. And it can be multiple consults with the patient where we can discuss the images and the clinical findings and the history, and then if everything gets addressed properly and confirmed, then the patient, once they are safe to come over, they can travel to Sydney, and then we perform a physical consultation in Sydney with them. But usually by the time the patient come to Australia, to Sydney, majority of the tick boxes have been done, and the patient would have proper assessment from the physical, mental, psychological, and clinical aspect, and the planning would have been done, and then just a double and triple check happens here in Sydney. And it's very, very often that we do that, because we receive patients from international destinations on weekly basis, and we have been doing that very successfully. And then the patient need to be in front of us, where we examine them, and they come a week or so before the surgery, and then if everything is confirmed, then we proceed with the surgery. They stay for the rehabilitation period, like that can be 2 weeks, and sometimes longer, and then they stay in the hospital for 3-4 days usually, which is the standard hospital stay for any kind of surgery that we perform, with certain exceptions, obviously. And then they go to a hotel next door to the hospital, and they come and do their physiotherapy. And once the wound is checked and clear, they can travel back home. And the follow-up, we hand them over to a local surgeon or local clinicians in their area of destination, but we carry on follow-ups regular basis with them on telehealth for the regular follow-up. If there is something urgent, then we can guide the local physicians and clinicians to what to do with that. And we've been doing this for over 10 years now, very successfully and very safely.
Mm-hmm. So given that she's only 12 years old, both of you do pediatric cases. Are there any special considerations for children?
Well, it depends. I mean, the definition of pediatric cases, I mean, we don't do the little bubs like the 1-year-old little kids. The 12-year-old is a teenager. So we are both adolescents. So we are very comfortable of treating anyone above the age of 6 years old, because their bone has formed. The bone formation as structure finishes around 7 years old, and then it goes into length growth. But the rotation, the angulation, most of that forms at the age of 7. So a 12-year-old is almost like an adult size. They're still growing, but their bone quality is treated as if they were, teenagers, and usually this is basically represent more than 30 or 40% of our practice. Mm-hmm. This age group. Is that right, Kevin?
Yeah, I don't know the actual numbers, but it's at least a quarter of those patients are.
Yeah.
Well, you know, certainly less than 20.
Yeah. Yeah, I mean, young patients at this age group, especially patellofemoral problems like anterior knee pain, deformities, is very common in this age group, and we treat them all the time.
So I'm going to segue a little bit here. Both of you are very accomplished joint replacement surgeons as well. Can you tell us a bit of the work in the joint replacement space? Maybe Kevin, go first.
Sure, joint replacements. It's an interesting thing. My interest in joint replacements, I do almost no primary conventional standard total joints. All I do is complex revisions, and most of that is infection. And it's a bit of a funny thing. I'll give a talk and something on making the diagnosis and you know, this sort of thing. And people say, oh, but patients don't come to you with a red tag on them saying they're infected. It's like, yeah, they do. All the patients I see, they come in, they have had 18 other operations or, you know, 6 other revisions for infection already. The patients that come to me, I am the man, the port of last call. I'm the last resort before they're going to have an amputation or a fusion, and often that is still their best reconstructive option. So I don't do. Munjed has a big practice in primary total joints, and that's a lot of his bread and butter. That's what you know, pays the bills in some fashion. He'll tell you that himself. I don't do that. I do a lot of the work that's public work at the Royal Brisbane, and all those infected revision total joints are, you know, they are complex, difficult. You won't make a great living doing that kind of work because they take so much time. They're so high risk, and there's not enough volume of it to you know, make that how you earn your income. It's just not possible. It's very demanding and frustrating at times, but in fact, that's what I like to do. So.
Yeah. I mean, I agree totally with Kevin. I divide my practice into two separate practices and actually 2 separate days, because on Wednesday I do the complex limb reconstruction work, and that include the infected joint replacements, severe deformities, major revision joint replacements, which represent a big bulk of my work. And I have special interest in that, similar to Kevin, because it is challenging. It is it's very interesting, and I dare to say we are very good at it, and very good at. I mean, the same thing in Sydney. I'm almost the last point of call for patients that have stayed short of having an amputation. So they come to us when they are at their last tether and they had multiple revision surgeries and failed operations. On the Friday, I do the primary joints, and that's basically what provide the income for my practice, because primary joint replacement is, with all due respect to primary joint replacement and joint replacement surgeons, it's the simple simpler kind of work, and it's very almost autopilot. It's all robotic. It's all highly sophisticated, and we do large number of them, and very successfully. But that's basically generate the income for the rest of the practice, because we can't survive on doing the complex cases because of the nature of it. It takes long time. It's very complex, riddled with complications, and
you will not get rich doing that complicated stuff. It's just,
and by the time the patient get to us, they have run out of all their funds, and they unemployed, most of them, because of their disability.
But you know, we are happy to provide the service. It's a necessary service. We do great things for them, and they're very appreciative, and we're happy to do that. But no, you won't make a great living doing that. And I make this analogy to playing basketball. So doing joint replacement, routine joint replacement, primary total hip, primary total knee, that is like shooting a free throw. You get everything all lined up, everything stops, you get everything set up perfectly, you stand there, and then you shoot the shot. And about 90% of the time, if you're a good surgeon or a good free throw shooter, yeah, you make the shot. That's pretty good. 90% of the time, good. Whereas doing complex revision infected work, that is like the NBA finals. You have, LeBron James and Michael Jordan and Magic Johnson all fighting against you. And, it is complicated, difficult, and the chance of winning all those games is very small.
Yeah.
Mm-hmm. Mm-hmm. We happen to have a live question regarding a recent hip replacement on a relatively young patient, 45 years old, which has resulted in a very large leg length discrepancy.
Yep.
So now this patient is tossing up a hip reversion versus a distal femur shortening versus lengthening on the other side. What are your thoughts?
Well, this is a very common. Unfortunately, it's a very common pathology and very common problem. And the way I look at it, I see this often, and it can happen to any patient. It can happen to any surgeon. Unfortunately, the question is that was it done anterior approach? Was it done posterior approach? Because with the anterior approach, you can pretty much assess the leg length discrepancy a bit more accurately, but you don't get it always right. So I divide that into 3 different categories. Category 1 is the patient who are within 1 centimeter of leg length discrepancy and they don't feel it. That category of patients, they are the ones that would do well regardless, and they fine. But obviously, the patient who's asking the question can feel it.
Lateral approach that was done before.
Lateral approach.
Mm-hmm.
Okay. Category 2 patient are the patients who are within 1 centimeter, but they can feel it. And that group of patients, I would err toward using an insole, a shoe raise on the opposite side, and that usually is the conservative approach until the hip on the other side wear off, and then you can match it. The third category, which is the complex category of patients, and that's the category of more than 1 centimeter of leg length discrepancy. And that category of patients are, unfortunately, a difficult category. Now, when you lengthen the hip more than 1 centimeter in a patient, that fall into 2 categories as well: painful or painless hip. Because sometimes when you stretch the tissue, you get the center of rotation change and alters, and you end up with pain sometimes, especially the abductor muscles can be stretched and can tear. So if it is painful and if there is an associated soft tissue injury, then I would revise the stem of the same leg. Because you need to restore the center of rotation, you need to restore that hip. Shortening the leg will not fix that problem, because you would shorten the leg below the area where the tissue is stretched, and the symptoms may not resolve. Shortening the leg is not a safe procedure. I much rather lengthen legs than shorten legs, and I don't know if Kevin agree with me on there, because it's not a risk-free operation. Shortening leg is not an easy operation. From our experience. So we lengthen patients every day, but we rarely shorten patients.
Yeah.
Oh, you agree with that?
Yeah, I agree. I think that the shortening procedure in the past, and I've done many shortenings in the past, but I think they are greater risk. You do, depending on the magnitude of the shortening and things, and sometimes there's still a role for if you have a very, very big discrepancy where you can shorten one and lengthen the other one at the same time. But that's the only real role for it anymore, for the most part. Again, lengthening, we'll probably talk about it later, but a lengthening a femur with a telescopic nail has become the easiest operation I do. Yeah. It's the easiest operation by a mile.
Yeah. Operating on the opposite leg is questionable because you don't want to operate on a healthy leg. So you deal with the problem on the same leg. My advice is that for the patient who had the surgery, to go back to their surgeon, tell them that they are not happy. And if the surgeon, one thing is very important is that a good surgeon is a surgeon that knows their limitation. And if this case, and I see that all the time, unfortunately, is that the surgeons hesitate to refer the patient elsewhere to someone who can deal with it. If the patient is not satisfied with the answer from the surgeon, then they can get to someone who knows what they're doing with lengthening or shortening or revision replacement. But the patient need to be assessed based on their own merits. If the hip is asymptomatic but pain-wise, but they feel the leg length discrepancy and it's more than 1 centimeter, and there is arthritis in the other hip, there is a room of operating on the other hip and making a hip replacement on the other side. But that's the only time I would do that. So I would rather address the problem on the same hip that has been injured. Kevin, what are your opinion?
I agree completely. Your discussion covered all the bases. I actually just saw a patient about in the last week that I did a fix and replace. They had an acetabular fracture, and I fixed his acetabulum and did a total hip replacement in the same operation. And then he's come back and he says, "Oh, his leg feels so much longer." And then we got the X-rays. We made, and he's 4 millimeters difference. And he wanted me to, revise it. It's like he's only 6-8 weeks out now. And I said, "Well, just sit on that, wait on it. You could easily put a tiny lift in your shoe, or when your other hip, you need a total hip on the opposite side. That will make you a little bit longer, and just leave it for that." So, I would not go back and revise this thing to change 4 millimeters. It's this much difference.
But as a hip surgeon, I see for second opinions, leg length discrepancy is the most common complaint that I see from patient coming in to see me for a second opinion, because they are not satisfied with their leg length from the operation that they had elsewhere. So it is very common, unfortunately, and it is not that easy to get right with a hip replacement. You try your best to get it right, but it is a problem if it's symptomatic.
So while we're on the topic of hip replacements, I know, Munjed, you're very passionate about this no gap joint replacement project. Can you tell the patients a bit more on what this is?
Yeah, so we have in Sydney, we have a contract with a couple of hospitals now where if you are privately insured so there will be no out-of-pocket expenses. It's an initiative for patients who have health funds that if they I do my hips and my knees robotics and anterior approach, and patients recover very fast normally. So if the patient go home, they get the physiotherapy for 6 weeks out of no out-of-pocket for free, and they don't get charged by the surgeon any out-of-pocket. They don't get charged by the anesthetist or the assistant. I'll be doing the surgery myself, and they get the best care basically at the hospital, and basically the health fund shift the money that they give to the inpatient rehab to the surgeon, anesthetist, and the assistant and the physio to cover for that basically, and they still save money. So it's a good program. We've been doing it for over 2 years now, very successfully, with very good outcome with patients. So I think this is the future. It's because the last thing patients want to do is that they pay enormous amount of premiums, and on top of that, when they come to have a hip or a knee replacement or a revision hip or a knee replacement, they pay out of pocket on top of that, which is unfair.
So we're going to circle back to some osteo questions. Combining these two topics, maybe Munjed, you can go first. What is a complex osseointegration case in your opinion?
I categorize patients with amputation to 4 categories, and you have the first category is a patient that is wearing a socket, but they are struggling with it, and they have very minimal use of it. That patient is relatively a simple patient because you can make them much better by providing them with bone anchor prosthesis or an osseointegration. Most of the time, these patients are would gain a lot and lose little, because the benefits outweighs the risk. So that's, and regardless of the physical complexity is a secondary issue. It's the patient that's the primary focus. The leg itself or the arm itself, it's not a big deal, because we can put an osseointegration device in the most complex bone. The second category is the patients who are basically wheelchair bound. They can't walk due to one reason or another, and they are the easiest patient because you will gain massively by making them walk again, and you will lose nothing basically by giving them the chance and the hope. Then you have a third category of patients, and they are the dangerous patients, because they are the patients who are performing extremely well, but they want to have better mobility. And they are the patients that they can gain a little bit more mobility, but on the expense, they may lose a lot. And they are the patient that requires significant amount of counseling and these are the category of patients who are healthy young adults, who are very well socket users, that have no issue with the socket, but they want to increase their activity level. And they are the ones that I reluctantly offer them the procedure, because I can make them worse potentially. Then you have the fourth category of patients, which are the most complex patients, and they are the ones who blame the world for the problem that they have. And regardless of whether they are wheelchair bound or active users of socket or strugglers, they are the patients who will focus and fixate on problems rather than solutions. And they are the patients that they need significant psychological counseling and significant change in their way of focus, because that is the category of patients that no matter what happens, no matter what you do, you cannot help. And unless they change the whole demeanor of their perception and focus on life, it's very easy for me to say that because I haven't lost a limb, and I don't know what I would feel if I lose a limb, and I have a lot of empathy and sympathy to these patients. But by the same token, in order for the patient to continue with their life, they need to move on, and they need to fixate on getting better rather than the problem itself. And that is the most complex patient to deal with, because they come with a massive baggage with them, and that requires a lot of undoing and unpacking and then building up again.
Yeah,
So
their expectation is that the surgery is going to not only improve their mobility, but their divorce. Oh, it's going to get them a new job. It's going to get them a new wife. It's going to solve all their problems. No, it's going to solve the one problem. It's going to enhance their mobility, but not take care of all these other problems.
Yeah.
Mm-hmm. Mm-hmm. So that's why the psychologist is such a crucial part of the whole
Absolutely.
assessment.
Yeah.
Mm-hmm.
Yeah, we work with a lovely guy, Chris Baston, and great relationship there, and he does a fantastic job of sorting it out with us.
Yeah.
Mm-hmm. So diving deeper in on the complex, the physical complex cases, we talked a little bit about short stumps, but what about hip disarticulations? Can you treat that?
Yes. So we have performed 5 hip disarticulations with osseointegration successfully so far, and these patients have walked. I have one patient who stopped walking, and that is because they have dish, and unfortunately their back issue is a major issue, and they have major pain issue. But the other 4 patients have been successfully mobilizing very well. Hip disarticulators, more than 95% of them end up in a wheelchair, and
within 2 years.
Yes, and so they are one of the biggest beneficiaries from bone anchored prosthesis or osseointegration. So we started doing hip disarticulators, and we've done 5 cases so far, but I can see that there is a massive opportunity for helping a lot more patients with hip disarticulation once more awareness become available to people who have disarticulation.
And also, while we haven't done the case yet, in concept, we do have an idea for how to grow a new femur from the acetabulum, and
Yes.
And that will be really exciting. You know, somebody will be the first patient. That's just how these things go. But this is, I think, a very creative and innovative way that's never been tried before. But when you are faced with difficult problems, sometimes you need to come up with very interesting, innovative solutions that have never been used before. And I think this is a great possibility. It has great potential.
Absolutely, I agree. I totally agree with you.
You know what I'm talking about. And
Yes.
we won't go into the specifics, but there is potentially a way to grow from the pelvis and acetabulum a new femur.
Yes.
Never been done by anybody anywhere in the world.
That's how medicine improves throughout the world. So talking about pushing the boundaries, the possibility and success rate of osteo with diabetic and vascular patients. Why are these patients in general a problem? And this question is from someone in the Gulf region, since they have a lot of diabetic amputations.
Yeah, I mean, this is a very good question. And the answer is very simple. These patients are not a problem. These patients will be the future of osseointegration. People have criticized me and criticized our team for doing diabetics and vascular. As a matter of fact, there are papers that we are publishing showing that diabetics and vascular patients are not worse off than standard osseointegration patients. The balance is there. Diabetic and vascular are lower activity patients, so they have less complication when it comes to activity-related problems. Patients that are healthier, they get more prone to develop complications such as granulation tissue, leakage, and infections because they mobilize a lot more. So we just passed the 10 years for my first diabetic patient and vascular path. He was 74 when I did him. He's 84 now, and we're publishing a paper on this patient. We have done over 50 diabetic and vascular patients successfully so far. So it is, in my opinion, will be the future for patients.
Mm-hmm.
Yeah, well, I've been saying for, I don't know, Munjed and I have worked together for 9.5 years. I met Munjed 10 years ago. We started working together 9.5 years ago. It took me about 6 months to set things in motion and get prepared to spend part-time in Sydney on a regular basis. And that's worked out beautifully, and we've had a great partnership. But that is something that I've been pursuing for about 6 or 7 years. I think we need to do an RCT, a randomized control trial, diabetic foot with standard of care, meaning total contact casting and wound management and blah, blah, and all this other stuff, or amputate, osseointegration, mobilize, get on with their life. To me, it is so clear. They will, the osseointegration patients will win hands down. I have no doubt about it. It's almost an easy bet.
Yes, absolutely. From our experience,
I would put a
they've
lot
done
of money
brilliantly
on
well.
that.
Yeah.
Who's going to do better? It's very clear.
That's very, very exciting.
Yeah, I mean, the evidence is very strong that diabetics and vascular patients do very well with osseointegration, and they are not high risk.
No, and with you already, the diabetic foot, the diabetic ulcer, and those people that have ulcers, chronic ulcers, and need wound care, and spend so much of their life going back and forth to the hospital managing their diabetic wounds. No, they'll be so much better off with an amputation and osteo. But the fear is they know the data is such that if they have an amputation on one side, they're very likely to get an amputation on the other side within 2 years, and their mortality is higher, and their mobility is less, and their quality of life is less. So they're so reluctant to have an amputation. Whereas if they have amputation with osteo, no, that takes all that out of the equation, and they will mobilize and walk and move on and get on with their life and be happier and better, and not spend so much of their time in and out of hospital managing these wounds in their feet.
So suppose in a way you keep them alive.
Yeah,
Yep.
it extends it. We did the mortality. We wrote a paper with Jason in one of the JAMA network journals, I think, that was mortality associated with osseointegration. No, there's no increase in mortality, and I think we haven't specifically looked at the risk of mortality in diabetics and dysphascias, but there is if you have an amputation and you're diabetic or dysphasic, yeah, you have an increased mortality rate. But with osteo, no, there was no change in your mortality rate.
Absolutely. Yeah.
It's very promising for a lot of patients out there.
Yeah.
So with a lot of these amputations, there's issues with the nerve and neuroma, and there's often terms such as TMR and RPNI being spun around. Can you talk about what this is and how do they work, Munjed?
Yeah, I mean, this is the Achilles heel of amputation, and unfortunately, when you cut nerves, you run the risk of creating neuropathic sensation, neuropathic pain, phantom sensation, phantom pain, and chronic pain. We don't have the perfect solution. We don't have the perfect answers, but we have modalities of care that stems from pain management, injectables, orals, intravenous, radiofrequencies, pain stimulators, and then nerve work, whether it's targeted muscle reinnervation or reorganization of the RPNI for the nerves. And we try everything, and the success rate is in the vicinity of 70%. But if a patient have phantom pain, have phantom sensation, the chances of eradicating that is very small. But you can manage it to a certain extent, but they keep coming back, unfortunately. So I concede defeat with hands down on that subject so far, but we will not give up from continue to try to help patients, but we don't have a good understanding. No one does have a good understanding of how the nerves work, and if they develop if they switch on and they develop the phantom pain, how to switch it off. Kevin?
But I think that it's nerve dependent. Hasn't our experience been pretty good with saphenous nerve? I think saphenous nerve responds beautifully to TMR. I think the other nerves less reliably. I think sciatic, we've definitely given up on sciatic. I think TMR is not the right approach. RPNI
we have some
may
good
have some success. But for the saphenous nerve, it's my impression that they do extremely well with TMR because it's a purely sensory nerve. So for those of you that don't know, nerves can be just motor, meaning they just power muscle. They can be just sensory. They just give the feedback back that there's pain or some touching something in some part of the body, or it can be a mixed nerve. And many of the nerves are mixed nerves. I think the mixed nerves are hard to manage. The purely motor ones, the muscles, you don't get any phantom sensation from those because they don't deliver any sensation. But the ones that are purely sensation, like the saphenous nerve, that I think we can do pretty reliably with TMR.
Yeah.
So the whole concept of TMR and RPNI, just so that I'm clear on this, is that we reroute the nerve and innovate it into a new muscle group.
Well, they're two separate. They're both dealing with nerves. So with TMR, it's targeted muscle reinnervation, where we plug the nerve and then plug it in, take the nerve, cut it, and then plug it into a nerve that supply a muscle, and then denervate that muscle, and that's called TMR. The RPNI is that when we get the sciatic nerve, for example, because it's a big nerve, we divide it into different branches in the fascicles, and then we get muscle, and then we chop it like lamb chops, very small pieces, and then we wrap these muscles endings, wrap the nerves with these muscle endings, and I use special type of collagen wrap, that is the nerve wrap, which is made of collagen, and that it looks like a piece of paper, but it's a collagen wrap, and wrap it around it and then embed it into the tissue. And that way it will wire this nerve and fool it that it's doing something useful. And by doing that, you would that nerve will grow into these muscles, and then will start functioning to some extent. There are two purposes of doing that. One purpose is to reduce the pain level by giving the nerve something to do, and the second purpose is that it provide an amplifier for myoelectric prosthesis in the future.
Yeah. It's interesting, TMR. I actually first learned about it in 2009. I was out at Harborview in Seattle. My good friend Doug Smith, who I finished my training. I learned to do limb salvage and reconstruction. Doug Smith went to Seattle and worked there with Ted Hansen, and they have a very active amputee program. And there at Harborview, one of the biggest trauma centers in the U.S., they do almost no limb salvage. They amputate everybody. But Doug became his special area of interest, and he introduced me to the concept of TMR at the time. I think he learned it from Todd Kuyken, who Munjed knows, a rehab physician at Northwestern in Chicago. Anyway, blah, blah, blah. Yeah, for 15 years, we've been exploring this as an option, and having some success in some areas, and other areas still haven't solved the problem. But I think we are making progress. Other people in and around Ian Valerio and things, I think at Ohio State in Columbus has worked on it hard, and other people, and we are making progress.
But definitely, I can say comfortably that we have done more TMR and RPNI than anybody else in the world.
Yeah. Sadly, we have never published any of it.
Yeah, we should.
We've
done hundreds of cases.
We've done so much of this sort of stuff. Yeah, and
people come and talk and publish and present about 5 or 10 cases that they've done, but we've done over 400 of them. But because we're still learning about it, we don't know where to, I mean, we need to publish on it for sure, because it's the work that we've done, and now we reach certain level of maturity about understanding how to do it, but the outcome is unpredictable, and that is the problem.
And you typically do it together with the osseointegration surgery.
Yes, and usually if a patient has phantom pain, we do it at the same time. If we are doing an amputation, we do it at the same time. I do all amputations with TMR and RPNI unanimously now.
So on the topic of nerve and pain, this other topic called CRPS has attracted a lot of patients. I think we've built a little bit of a profile on knowing how to handle this. First of all, what is CRPS?
Kevin, do you want to start?
Sure. Well, these chronic pain syndromes and things, they were first recognized with war injuries in the American Civil War. It was known as Sudex atrophy for a long time. And over time, it became chronic regional pain syndrome. It was neuralgia and these other sort of, there were other names that have been attached to it over the past 150 years. But in the last 20, 25 years, it's become chronic regional pain syndrome. And there are very specific diagnostic criteria, and there's the Budapest criteria. Even though they are very reasonably strict criteria, no, they're pretty open-ended, really. There's these 5 criteria, of which it includes, has it failed to respond to all means of standard non-operative measures? Yeah, okay, but if it's failed, well, that's one criteria. But if it, anyway, the criteria are not especially strict. There's a lot of interpretation to it, but there are criteria. And if you have failed to respond, if there is no other apparent source of the pain, no obvious other, you don't have a fracture, you don't have a non-union, you don't have an infection, sure, nothing else going on, and you can only attribute it to the nerve pain, then this falls into that category. And it historically has done terribly. People with these kind of, you feel really bad when these patients come to you because they are so disabled. They have otherwise often a normal looking foot or leg, But in fact, no, they have this terrible, terrible pain. And then because they can't use it, they get severe osteoporosis, disuse osteopenia, which I don't think is really disuse, because when you look at the x-ray, it goes to a certain point, let's say in their distal tibia, and then from 10 centimeters from the distal tibia, it becomes very dramatic, this very dramatic change in the radiographic density of the bone. Now, the tibia on the other side of that line is also being unloaded. So it can't just be the fact that they can't weight bear. It's not disuse. Yes. I think it is neurogenically generated. I think it's driven by the nerves. Anyway, the diagnosis that needs to be made by someone who's an expert in nerve pain and problems, and a neurologist, but we don't, as much as we can make that diagnosis, we can walk in and say, oh yeah, you satisfy these criteria. We leave that to other people to make the diagnosis, because then it distances us a bit from that decision-making process. We don't want to come in and say, oh, you have pain and problem. Well, if we call it CRPS, it has certain implications that makes things difficult from a medical legal perspective. But all that aside, yeah, it is a very recognized symptom, and rather syndrome, and they have discoloration of the limb, perhaps. Sometimes early on, it'll be very bright red and sweat a lot. They'll have this hyperhidrosis and hyperemia, and then later on, it kind of burns itself out, and then they get cold and blue. So initially, they can be very swollen, warm, red, and later on, the same patient has a leg that becomes cold, blue, and becomes dystrophic and loses muscle mass and things, again, because they develop contractions. So the management of these, historically, when people have suggested, oh, just amputate that leg, it's a useless, painful leg. No, they have worse problems, because then they have a shorter leg, an amputation, and now they have the same pain. It just migrates up, because Munjed has done a very nice job of, when you see these patients, you need to identify the level where they have a normal neurology. And that is what determines where the amputation is done. Is this correct, Munjed?
Yes.
Yeah.
So basically, exactly what Kevin said, I totally agree. It is a very complex problem. The diagnosis is very critical. It need to be diagnosed by someone else, because we don't want to carry that burden. But we
Even
have
though
established.
we can pick out those patients and identify them.
Yeah. Yes.
But I think it is important to have an independent diagnosis.
Yeah. And we have developed the CRPS unit. Now it's a multidisciplinary unit, including rehab physicians, pain specialists, anesthetists, surgeons, and researchers and psychologists. And basically, it's the first unit in that I know of in the world that specializes in CRPS. We see CRPS patients on regular basis, and basically we are in the process of developing a protocol of management of these patients, depending on the categories that they come with. But ultimately, some of these patients may require amputation, and the importance of dealing with these patients when you amputate is to have proper pain management. They need to be preoperatively optimized, perioperatively optimized, and postoperatively optimized, in order to allow getting the right level of amputation, right treatment with the pain management and with the nerve work, and then the right follow-up for these patients, so they don't develop CRPS in the stump. Unfortunately, it is a possibility that this happens, and I had a patient that came to me with a CRPS in the wrist, and then which is a sad story, that went back to their surgeon. I offered certain level of amputation. Unfortunately, got the wrong advice from a rehabilitation physician who specialize in upper limb rehabilitation, ended up with below elbow amputation, and CRPS got caught into the stump, which his life is now. He doesn't have an arm, he doesn't have a hand, and his CRPS is much worse. And my advice was to amputate above the elbow because it was very clear that the elbow was involved. So you need to be very careful with management of CRPS patients. And
it's quite an interesting syndrome. I mean, it's fascinating. Sometimes they have a very minor injury, for instance, an ankle sprain. People get ankle sprains all the time, and they recover for the vast majority. But they can have a minor injury and then have this pain out of proportion to what the injury you would expect, and then it aggravates itself and feeds on itself. It has this feedback loop and just accentuates itself and gets worse and worse and worse, and it's very difficult to manage.
Absolutely, yeah.
So, what is the success rate? How many patients have we treated, and how many actually were we able to fix?
We've treated over 20 CRPS patients to date, and I can say that
With osteo.
with osseointegration and amputation, CRPS patients, when they get an amputation, they are not suitable for a socket because socket stimulates the stump, and that they have a higher risk of developing CRPS in the stump. So they need to have osseointegration if you get an amputation, or they choose to stay in a wheelchair and don't wear a socket, because trying to wear a socket is, in our opinion, is contraindication for CRPS patients. The vast majority of these patients have recovered, and some of these patients have had some residual pain. Some of these patients have developed phantom pain, and we have recurrence of CRPS in very small number of these patients.
Yeah,
but the majority have done well.
We did write that paper on the first 5, but I think it's something,
yes.
Again, there are so many things we could write papers on and do research and publications, but this would be an important topic to address in the bigger series of, whether it's 18 or 20 or whatever the number is now, to better reflect our experience.
Absolutely, yeah. Yep.
So there is hope there. We encourage patients with CRPS to reach out to the team. I think we do have something that we can offer here.
Yes.
So
sure.
We have one more question that's on the general topic of osseointegration. Someone has asked, why isn't osseo done as standard when someone has an amputation? What does it take for us to get there?
That's a very good question, and I think it should be. But as with any innovative technology that is new, you face challenges. Sir Charlie in the 60s, in 1962, he was ridiculed and criticized for inventing the modern technology of hip replacement, and it took years and years before it becomes the standard. So I hope it will be in our lifetime that this will become standard. But because it's still relatively a new technology, it's still facing challenges of acceptance. There are many aspects of it. You have the pseudoscientists that claim that they know everything about osseointegration, and they come out and critique it and criticize it. And then you have the people who have financial interest in not allowing this to go ahead, because with osseointegration, you need to understand that you're taking a big group of people out of business when you provide osseointegration, because you're shifting the model of care from the prosthetist to the surgeon and to the clinicians in the hospital, because they don't get socket anymore. So it's not in the interest of any prosthetist to advertise for osseointegration. I say that bluntly and openly, because it doesn't make any sense. And for years, every conference I go in, I get the first question I get asked: are you getting us out of a business? So now prosthetists are realizing the benefits of osseointegration and starting to accept it more, especially for people who are struggling with the socket. And people who are not doing well with the socket, and they are the headaches. of the prosthetist. So it is taking time and trying to make people understand that it's like the industry of cameras. When Kodak lost a lot of business with the digital camera invention, and everybody's saying, oh, it's not a real image, it's horrible, and you need to develop films and all that stuff. And then now tell me anyone that is developing films anymore. It's all digital
it's a
now.
niche, yeah.
Yeah.
But you know,
So
this goes back. In 2016, Munjed and William and I went to a conference in Washington, D.C., Extremity War Injuries 11, that was sponsored in part by the U.S. military, Department of Defense, and they had an interest in osseointegration. They invited us, or we submitted an application, and et cetera, and we were invited to present. And the question came to us, the big question they want to know is, what is the biggest impediment to moving forward with osseointegration? And I told them right then and there, it was the backlash or the resistance you get from the prosthetists. We
Absolutely.
are taking their job, or really, it's not, they need to adapt, and they fill a different role. They'll still fit patients, they'll still make modifications and adjustments, they'll still sell the prosthetic legs, they'll sell fittings, they'll sell connectors, they'll sell dual cones, all these things that they will. It's just a different practice for them. It's a shift in their focus. Instead of fitting people with sockets, they're instead still selling the legs, but they need to fit with connectors and dual cones.
Yes, absolutely, and that's the thing. So as a matter of fact, they will sell more legs, because with osseointegration patients, they become much more active, and they wear their legs much more frequently, the prosthetic legs. So it is business-wise, it's not a bad idea for
it's less labor for them. Right now, it's very labor-intensive to make a socket. That is a lot of work.
Yeah.
Fitting the digital. Now they do some laser scanning. They do some digital this and some AI generated. I see some of that also being introduced and perfecting the fit for the socket. But yeah, it's a lot of work.
So both of you work in the very tip of the modern orthopedic surgery. What are some recent innovations that you see, or some new findings on the studies that you wish to share with the audience?
Yeah, well, I think that we have explored and been very active in the 3D modeling and virtual procedures and designing implants. Munjed and I design custom implants and custom devices all the time. And whether they're, so I think that's one area that the things are moving forward quite predictably. I think that it's a long way still from every routine procedure being a patient-specific implant, for instance, for fractures and things. So many of the implants we already have work beautifully. You don't need to have patient-specific implant for everything. But for complex, difficult things, yeah, there's a good role for it. So I think that is one thing. I think another thing, I have worked with a number of different ways to grow new bone for the segmental bone defects. That's a separate thing. I think that finding a replacement for bone graft, meaning we have a way now of making a biomimetic hematoma to deliver growth factors, including bone morphogenetic protein, much more effectively. I think that's really proving to potentially be a really big advantage, and we're excited about the potential there. I think this is a really big area that we are actively exploring and looking at, and we've had great success with it so far in a limited number of centers. There's only 3 centers in the world that have access to that technology, but all 3 of them are reporting very good outcomes and results so far. And so, BMP has been around since 1965, discovered by Marshall Urist in 1965. The problem is delivering it. And when you put it on a collagen sponge, which is the way that it's been used since about 2002, when Medtronic, they got the approval to use it for non-unions and also for spinal fusions. You put it on a collagen sponge, it doesn't actually control it very well. So as soon as the muscles, or as soon as it gets squeezed, it just squeezes out of the sponge and then goes everywhere and forms bone where you don't need bone, etc. So, and in the lab, we've looked at it. Using a collagen sponge deactivates the BMP, so that putting it into this hematoma that replicates. When you have a fracture, you form a fracture hematoma. We make a very special recipe to take some of the patient's blood. You take the blood out, you add a bit of this, a bit of that, little the secret herbs and spices, and in fact, no, you can make a hematoma that replicates very accurately a normal fracture hematoma. And if you add BMP to that, it makes it 60 times more effective way to deliver it than putting on a collagen sponge. It's really amazing technology. It works extremely well, and we're very excited about that.
Munjed?
Yeah, I think the area of interest that I have is in customization for implants, bone defects. I have a different approach to Kevin. Kevin tried to restore bone with the bone defects. I usually with the pelvic bone defect, for example, I tend to customize 3D printed implants, like made out of titanium. Sorry. Yeah, but you have a special interest in the bone defect in long bones, which I don't have that experience. So that's an experience I don't have. That's your experience, and you're the world leader in that field, which I can't claim that I have experience in. But my experience similar to yours with the bone defect in the pelvis, and by printing 3D printed implants, and like titanium implants, and which is but at the same time, we do fair bit of bone transport, bone lengthening, and create bone through that approach. But definitely, we utilize the latest technology that is available to us, as with the help of very, very innovative engineering units that work with us, basically.
Yeah, I think that we're lucky to work together. We think a lot alike about a lot of these problems. I think that we are, there is no box, not just outside the box. There is no box, and we take approaches that no one else has ever considered anywhere. And you and I often come up with the same solution. We sit there, and the light goes off, and the two of us look at this thing and go, "Yeah, let's do that." And having Mustafa there together, we give him a bit of guidance of where we want to take it, but he can do the virtual surgical part of it. And then the engineers that you have put together in your unit there in Sydney that work with us, they are also on board. And so it becomes it's sort of this little bit of chemistry that works out really well.
Yeah, absolutely.
All from the benefit for the patient.
Yeah. Obviously, the focus is the patient.
So, I know, Kevin, you used to work a lot with external fixators. Now, with all this new technology, is there still space for external fixators?
Yeah,
there is. I think certainly we use as temporizing frames, and I think that in much of the world, it is still the go-to for regenerating bone and lengthening bone. In many parts of the world, it is definitely still the go-to. And I think that in and around the foot and ankle, definitely the best way to regenerate bone, using Ilizar's principles of gradual distraction and distraction osteogenesis. Sure, the telescopic magnetically controlled nails and other powered nails that are telescopic designs, there are a number of different manufacturers, and all of them in the end do the same thing of gradually extending out one smaller nail from inside a bigger nail and growing the bone. That works extremely well for the femur. It has revolutionized our care there, because having a fixator on your femur is difficult for an adult, certainly. wearing clothes, for instance, difficult with a frame, using a toilet, difficult with a frame, routine activities of daily living, very difficult to accomplish with a frame on your femur. For tibia, yeah, you can manage it. It is manageable. But you would prefer to have something all internal if possible. And so even there, it is a race to come up with different ways to minimize the amount of time in external fixation. And again, some very clever things are being done now with balanced cable transport. Steve Quinnen, who was one of my fellows, again, 2009 or so, has taken this to a different level. And one of his fellows, Roberto Hernandez Izquierdi, who's now at Emory in Atlanta, has also taken that to another level. And there's other people at various other locations in and around the world. There's an Austrian surgeon, Phil Linz, and some other people that there's a group of us that are familiar with one another, and everybody learns from the other guy's successes. But there are other ways to generate and grow new bone that still use external fixation. Balanced cable transport, I think, is an excellent way in and around the tibia, certainly with bad soft tissues and history of infection. And if you are less likely or more reluctant to put a telescopic nail into that environment, yeah, it's a great way to do things. So there's still a role for external fixation.
Yeah, we do frames. We used to do frames like 2 a week. Now we're doing like one a month or one every 2 months. We did a frame together just 2 days ago.
Yeah.
Basically,
there is less of a role for it as things, and we also go to even in, let's say it's an austere environment and you're in somewhere in sub-Saharan Africa. For patients there, doing an acute correction and straightening the leg is the most important thing. And so they'll have patients with rickets and things with terrible bow legs that are very dramatic, and you can shorten them acutely and correct those deformities and make them straight and make them much better. And then later on, they can undergo lengthening. This idea that doing everything as a gradual correction and lengthening and restoring everything in the Ilizarov philosophy, which still is very valid, and there are a number of great centers around the world that have really good experience doing that. But for most people in more sophisticated societies and things, no, using an external fixer and things for a long period of time, not as well tolerated, and instead we go to different techniques to try and minimize the amount of time in external fixation.
Yep.
Okay. We're just a couple minutes away from the 2-hour time mark. Just one more question. Yeah, we've already been talking for 2 hours. One more quick question on the osteo side. How strong is the requirement for social support for an osteo patient? Do you need to have someone, if someone is living alone by themselves, are they a good osseointegration candidate?
Yeah, I mean, with osseointegration, I mean, as long as the patient can manage to use crutches, they can. It depends on what level of amputation and what level is the osseointegration. If it's below knee or above knee, is it short, fast loading or slow loading? But for fast loading patients, they can load gradually over 2 weeks, and then they get fitted, and they walk with 2 crutches for 6 weeks, 1 crutch for 6 weeks, and unaided after. So it's not that extensive rehabilitation. For below knee or slow loading protocol, they load for 6 weeks, and then they get 2 crutches for 6 weeks, 1 crutch for 6 weeks, and unaided after. So it is one surgery. The rehabilitation is relatively straightforward and fast. So it's always ideal to have someone around, but it's not necessity.
Okay. In the very last bit, patients have heard a lot about medical stuff. They also want to know a little bit of your personal life. Maybe start with Kevin. What do you do outside of work?
First of all, I would work 10 days a week if you had longer weeks. we love to work. We are working people. Munjed and I just love to work. Me, outside of work, I like doing a bit of astronomy. There's the comet right now, Sushinchan, A3 2023 Sushinchan, is visible now right after sunset. So it's a really great opportunity. There's been lots of solar activity, observing auroras. So yeah, I have a graduate degree in astronomy after people say I'm pretty good with numbers, and so I do a lot of sort of math.
You are very good with numbers, Kevin.
Yes.
That's not good to say.
And
It's a fact.
I just it just comes naturally to me. So I do mathematics and stuff just for fun.
Yep. I
And
encourage
otherwise I play
patients to
basketball.
try it.
Yeah, I just play basketball. Yeah.
Yeah,
Munjed?
I'm too dumb with mathematics, but I play chess. I enjoy sailing, going on the harbor, and spend time with the children, basically. But we work. We don't have
You do a lot of work.
work-life balance at all, and there is no such thing.
It's completely off the scale.
Mm-hmm.
That has changed for me in the last year. Now I have a great relationship with a lovely partner and her daughter and things, and so that has persuaded me to slow down a bit. Now I don't work constantly. Now I just work most of the time.
Yeah,
Happy for you, Kevin.
that's good. We're all happy for you. Very
I'm
happy.
very happy. It makes me better. Yeah. It is good.
You look 20 years younger.
Gee, I must have looked terrible before.
Well, anyway, let's not talk about that.
All right. So I think this is time. It's been a wonderful 2 hours having you both. I'm sure a lot of patients would appreciate all these questions being answered. If we didn't get to your question, we will reply via text message or via email. If you didn't get a chance to send over your questions, you can still always contact us, and we'll try our best to get back to you as well. And stay tuned. There will be more sessions in the future, and we hope to see you all next time.
Thank you very much.
We never got around to stature lengthening and segmental defects, and
Yeah, there's always topics that we can.
Maybe we should have another webinar in the coming few weeks to do
Yeah, actually,
especially
yeah.
for stature.
I had as much fun as I thought, much more fun than I thought I would. Gee.
Okay, excellent.
Oh, we
We'll
have
do
a
that
comment.
regularly.
We have a comment that says Dr. Kevin looks like Tom Cruise.
But yeah, get
There you go.
out,
Excellent.
get out and see the comet in the next 2 weeks, right after sunset.
Awesome.
Let's go.
Okay, thanks very much, everybody.
Thanks, Kevin. Thanks, everyone. We'll see you next
See
time.
you, Kevin.
Chat soon.